afternoon. Thank you for having me. The paper I'll be presenting today is the distance of the femoral neurovascular bundle from the hip joint, and this is an intraoperative guide to reduce iatrogenic injury, which was published in the Journal of Orthopaedic Surgery and Research earlier this year. I have no declarations of interest. So the background to this, the femoral nerve is injured in 0.2 to 2.4% of primary total hip replacement, and this statistic increases to 1.4 to 3.8% in the revision setting. So the etiology of this is from direct trauma, hemorrhage, retraction and leg lengthening. And a recent systematic review demonstrates that the most common etiology of this injury is from retractor placement on the anterior acetabular wall. When these structures are injuries, it leads to a poor functional outcome for patients with ongoing weakness, paresthesias and neuropathic pain. And this obviously leads to poor patient satisfactions and impacts on their post-operative rehabilitation. Prevention of injury to these structures requires a sound knowledge of the anatomy of the native hip joint, and it requires constant vigilance intraoperatively to reduce the risk of this iatrogenic injury. So our aim was to use MRI to identify objective relationships between the femoral neurovascular bundle and the hip joint, and we also sought to identify correlations between distances and certain patient factors. So first of all, we gained ethics approval. We looked at consecutive MRI scans within our institution, regardless of the indication, and this was over a period of time between February to September 2017. Our exclusion criteria included patients less than 18 years old, prior surgery, severe deforming arthropathy, and movement artifact for obvious reasons. So our institution used either a 3 Tesla or a 1.5 Tesla MRI scanner with standard slice thicknesses of 4 millimeters. What we did was we looked at the axial proton density images at the level of the anterior acetabular retractor placement during total hip replacement, and we standardized this by looking at 2 slices, i.e. 8 millimeters superior to the teardrop. Then looking at the scan, we identified the nerve, the artery and the vein, and then calculated some distances. So we looked at the anteroposterior distance, the mediolateral distance and the shortest distance. And we used SPSS for our statistical analysis. Our study included 115 hips. This is with an average age of 56 and an average weight of 75.5. The most common pathology that was found in our MRI scans were of cancer, so often these are done for monitoring of cancer, with a smaller percentage with primary hip diagnosis such as OA or labral tears. So our results, the shortest mean distance we found for the nerve was 23.62 millimeters, for the artery 19.62 and the vein 17.47. And what we did was we looked at 8 millimeters, so 2 slices above and below that initial reference point, and we found there was minimal change in these distances above and below our set point. Interestingly, we found the nerve had the shortest distance of 13 millimeters, an artery of 14 millimeters and the vein 16 millimeters. There was no difference between left and right-sided measurements. We also found a statistically significant positive correlation between patient weight and shortest distance of artery and nerve, and a statistically significant negative correlation between patient age and shortest distance of vein and artery. So what this paper adds to the scientific literature is that we found that the femoral nerve is closer than previously identified. This is compared to Schubert et al.'s paper in 2015, which was 28.1 millimeters, and that included only 32 CT scans and 16 cadavers. We also found an at-risk population, and we found that in the elderly or the frail patients with low body weights. Limitations: the MRI was performed with a patient supine, which it obviously isn't applicable for all patients having total hip replacement depending on the approach used, and it's unclear if these relationships would change with the patient positioned laterally or with different limb positioning or after a femoral neck osteotomy. Definitely further study is required to investigate differences between male and female patient, the impact of deforming arthropathy or post-femoral neck fracture. A suggested further study would be an ultrasound study with the patient positioned laterally. In conclusion, the location of the femoral neurovascular bundle is closer than previously thought to the anterior acetabular retractor. There's a theoretically increased risk of injury in the elderly and patients with low body weight, and utmost care is needed in placing of anterior acetabular retractors, It's the guidelines of our authors that the tip of the retractor should be kept in contact with the bone along the anterior acetabular wall, and if the pressure is lifted off the tip of the homen or the position of the retractor changes, it has to be taken out and put back in the same manner to reduce iatrogenic injury.